Top Med Talk.
Today's Top Med Talk is about the COVID-19 crisis. This piece was recorded last year. However, we still believe it contains lots of useful information. Have a listen.
Our next guest is a friend of Top Med Talk and a personal dear friend. We're delighted to hear from Professor Angela Bader. Hello, Angela. How are you?
Hi, Desiree and Monte. It's always such a pleasure. Thank you so much for inviting me.
Many of our listeners know you, but for our new listeners, can you tell us a little bit about your background, your institution, what you do there?
Oh, sure. I'm a professor of anesthesia at Harvard Medical School, and I'm the vice chair for perioperative medicine at the Brigham and Women's Hospital, which I don't know if you know, we've now combined and we're called Mass General Brigham. We're trying to be one institution. So now I'm at Mass General Brigham, and I'm the vice chair for perioperative medicine. I have been interested in perioperative assessment and optimization, and that's how I became a friend of Top Med Talk and you guys in general. And so my research is on the area of preoperative assessment and optimization, which I am particularly focused on concordance with patient goals and values and helping communicate to patients and families making decisions about medical and surgical treatments, particularly in the elderly or seriously ill, which seems to be very, very relevant at this particular point in time with the COVID issues.
Making those difficult choices, I mean, there's a lot of discussion in the popular press at the moment about the concepts of rationing or scoring people. That is part of everyday life in medicine, not from the point of rationing, but from the point of view of making rational decisions, because major interventions, whether they be critical care and mechanical ventilation or having a particular major surgery, it's not a slam dunk that it's in the patient's best interest, irrespective of age, to have those things.
I don't use the word rationing ever. I use the word concordance.
Yeah.
Because what I actually find is that, and I have these discussions all the time with patients and families, is in general, I have found that concordance with patient goals and wishes, if you take the time to actually communicate, you often find that the decisions are rational. But that takes communication skills. So I completely agree with you. And I think we underestimate our patients in terms of this idea of rationing. I really think I like to focus on the term concordance, and I'm writing a lot using those kind of terminology and staying away from rationing. And I think you made a very excellent point, because when people talk about rationing, there's this underlying implication that having something done will make you better. And that's why we have to do it and then ration it. But as you and I and Desiree all know, that isn't necessarily the case, and your trajectory may actually be worse. And I think that's where it gets away from rationing. If you can make patients understand that just having something done does not mean that you will be better afterwards. So that I think is what is an important point in the communications.
What does it look like there at your hospital?
Yeah, so what we've done, I think, I'll tell you, one of the very good things that has come out of this is all the little petty differences seem to have disappeared. And everyone, from whether it's sort of the front desk assistant or the, ICU attending, is on teams, and they are deploying teams in a certain order depending on the patient census. Right now, we are actually still have capacity. So, I'm watching what's going on in New York and things like that. So a lot of people in their regular roles, even down to people that used to do scheduling, are now handing out masks at the front door or, all of those kinds of things. So I think it makes everyone at every level feel involved. As far as my personal role, It took us a while, but we really worked on cutting back on the surgical schedule. So I have been spending a lot of time looking at patients who were previously scheduled for surgery, speaking with them, speaking with the surgeons, and trying to make the best decisions about timing this surgery versus any impact on their prognosis. One of the big difficulties we're having here is the peak keeps getting pushed, the date of the peak. And so it is very hard to know if you have somebody, for example, that needs cancer surgery. Last week we were told that this week was going to be the peak. And now we're being told it's more towards the end of April. So it's very hard to make those kind of decisions when they keep sort of moving the goalpost here.
Yeah, because we are flattening the curve, they keep pushing the date out. Well, you're never, when are you going to peak? Have we truly seen the surge, here? So Monty, you were talking about that you guys are starting to ramp up your cancer surgery there in London.
Ramp up might be, which has become a favorite government transmission word here, might be slightly overstating it. It's definitely got a slope to it, if you see what I mean, and it's an upward direction, which is great. Yes, in particular in our sector of London. They've got themselves very well organised to try and do prioritised scheduled surgery, particularly for cancer, for example. And that started a week or so ago. And they're doing that surgery in some hospitals. It's a combination of a private and NHS combined endeavour, but run by the National Health Service, so equal access to all patients. And those patients get prioritised to come in, have COVID screening, to make sure everyone's safe from each other, and then go ahead and have their scheduled surgery. And that looks as though that's starting to happen effectively and well. Way, way, way off the capacity that we would aspire to, but it's great that there's a process in there.
Yeah. Angela, so can you tell us a little bit about your process? And I mean, Monty and I, we've really been talking about optimization of these patients, and it's more important now more than ever.
Oh, yes. The other question is, it is really an individual patient discussion looking at risk benefit of waiting. And I'll tell you, one of my biggest concerns, as I mentioned earlier, is bringing elderly, immunocompromised patients into a higher risk situation, which is something I never really would have thought about. I would be thinking about the timing of the surgery and optimization, but now it's also at what point would it be safer to bring them into the hospital? And that's the piece, honestly, I'm having the hardest time with. Is it safer for this patient to wait a week? Are we going to be safer in the hospital? I don't have any answer for that. And, but if I'm in discussions with the surgeon being told that it's really going to impact prognosis, then we have to accept the risk benefit and also obviously make sure that the patient and family understand it. So I think that's one of the things I'm struggling with the most. We were always talking about optimization and time-sensitive surgery to try to reach a balance. But now, in addition to optimizing the patient, it's sort of how do we optimize the situation at the hospital that we're going to be bringing them into? And I honestly don't know. And that's, and we seem to have these discussions every day. If we wait another week or 2 weeks, will it actually be better for this patient to be here, but we are delaying a time-sensitive surgery, and nobody knows the answer. Those are the difficult decisions.
Sure. What's the feedback that you actually are getting from the patients? What are they saying in this?
Well, many of them, because of all the issues that are coming up in the press, want to delay their surgery. I don't know, are you seeing the same thing there? But I'm having a lot of conversations which is actually good, because for the majority of them that can wait, it's actually good that they're thinking that way. And so I'm having a lot of discussions where they're asking if it's possible to delay. The problem is then they ask until when, and I don't have the answer. Is that what's happening in London as well?
It is very, very much so. The balance is between it's my knee's sore, it'll be fine, despite me
Yeah.
having a sense of urgency about it before, compared to I've had a diagnosis of cancer and I understand the challenges I'm up against, and I really don't want to wait too much longer.
Right, exactly. And that's the kind of discussions that we're having every day.
On those patients that are being delayed, but are eventually going to have surgery sooner rather than later and waiting until this crisis is over, what are you doing to optimize those? Because I know that you are big into the pre-op optimization and fixing anemia and diabetes, all these different modifiable risks. And some of those places are closed. They can't get in to see physicians and things like that. So how are you managing during the crisis?
Well, we are, I would say, being imaginative. So what we're doing is we are calling every patient. So the staff in my unit that have not been deployed, and basically what we're doing is a week deployed. They may be deployed somewhere and then come back, but the people that are in the unit are calling every patient that was scheduled and trying to figure out when they do come for surgery, is there something that we could be doing in the meantime to optimize them? But I have to say, as you know, that is very hard. I've been trying in some cases. We have something here called an e-consult. I don't know if you have something similar there. They'll do sort of a chart biopsy, and I ask a specialist, a cardiologist, to do an e-consult. In some cases, we're doing virtual visits, but it is very hard because most of the specialists' office are really not seeing patients in person either, unless it's an absolute necessity. But we're trying to be very creative about what we can do via telemedicine, e-consults. And I have to say, this has really brought forward, I'm sort of keeping a list, Monty, for things when we get through this that have come up. And the importance of telemedicine and how can we use telemedicine more in optimization in the future is really coming to the fore for me in terms of thinking about that.
We're going to be talking to Carol Peden this week. She's done an article on telemedicine, and then we're talking to Bobby Jean as well, Bobby Jean Schweitzer, who's a top MedTalk regular, about managing her anemia clinic in this crisis. And they were able to deem it essential, and so they're still running it.
Interesting.
I think we all agree there's a lot of good that's going to come out of all of this as well, mixed in with like everything is often the balance in the two. There's a huge amount that we feel we have to do in offices and get people to commute around that we clearly don't need to.
Exactly. I think the things that I am thinking about is number one, the role of telemedicine in optimization, which truthfully, I think is a little bit of an untapped resource. We've often done telemedicine for visits, but trying to plan this in terms of what optimization can be done. The second thing, which is particularly near and dear to my heart, is education and communication skills around end-of-life issues. And, I was in the UK because I was actually faculty at a conference for a Train the Trainers group for the shared decision-making program that I guess you're doing as part of Choosing Wisely. And one of the things that I would love to do is bring that in some form to the US. So I'm hopeful to be able to, in fact, we had submitted a research proposal, et cetera, which all got put on hold because of this. But I'm hoping that this will really make people think more about the need to educate clinicians in having these discussions. So if we can look at sort of the silver lining, I think those are two areas that maybe a new focus and good could come out of this also.
Yeah, absolutely. That was Ramai.
Yes.
I'm sorry. What is her last name?
Summer. I'm so sorry. I didn't want to attempt to pronounce it.
I know. At George at St. Thomas, and I remember her posting that, and what I thought she was explaining what you guys were doing, and that was absolutely fantastic.
Yes.
So Angela, we had a conversation with some junior doctors, some colleagues of one of our partners in Top Med Talk, Henry Howe, who just graduated and will be entering the workforce very shortly, and in medicine. And the junior doctors were saying that it has been an interesting time because they've gotten in there their first years, and they're already having to learn to have these really difficult end of life discussions. I thought that was really interesting, their take on the whole situation. How is that something that you are literally talking to your patients? What are you talking to them about?
The biggest problem, to be honest, is there aren't that many people in my department who feel comfortable having these conversations routinely. Obviously, the critical care people do, but it's not a part of our routine residency curriculum in the US. And one of the things that I have really been pushing for is to incorporate these because, some of us are very experienced, but we have to make sure that people who are entering the workforce at junior level have some facility with this. And it's interesting, I work with the students at Harvard Medical School, and I see more and more of them having an awareness of this existing even in medical school, although again, it's hard, there isn't really a good formal way to incorporate this into their curriculum. But I'm very, very hopeful that the group that are entering the health force now are coming already with an awareness into the surgical specialties, which is different, and that they will be open to these sorts of educational modules and projects. So I think I am planning on focusing a lot of the work once this is over. I think the key is in the education, because people may believe in it, but if they don't feel comfortable, it just isn't going to happen, or it isn't going to happen properly. Yeah. So actually, I'm just, with the time that I have in between patients now, I'm writing a manuscript on concordance when patients come in already with these. In the US, we call them POLST or MOLST, orders for life-sustaining treatment, and looking at concordance in surgical patients, which it's interesting. I have a couple of medical students from Harvard and a couple of residents very, very interested in this work. So I'm hoping we can build on that.
Angela, on the subject of informed decision-making, as you're reminding us of this very important subject area that I'm also very passionate about, what about informed decisions for us as providers? So, we recognize there does seem to be a greater risk to us. We recognize that we're in certain categories. Yes. How did you handle that locally? Was there choice?
Yes, it's very interesting. We are all worried about it, but it hasn't really seemed to deter people from really rising to the challenge. And it was something I think everyone was worried about, but I'll just say it's been really impressive to me. For example, with increased deployments in the ICU, we first started by just asking for volunteers, and there were more than enough volunteers. So I think everyone is realizing there is a personal risk, but I think it's a credit to the sort of personalities or values of people in the medical field that it just seems like everyone has been rising to the challenge, but it's not without a recognition of the risk.
Yes, because what do you do? Because for it's sometimes people sort of get the impression if you're in a clinical environment that you don't have comorbidities and diseases and take immunocompromising drugs, whereas we have the same spectrum as the rest of society.
Yeah.
What have you been doing about your colleagues who you think shouldn't go into the front line? Because asking to volunteer, clinicians, people who work in hospitals are always going to volunteer. That's why they want to do the job.
Exactly.
So how do you protect them?
Well, we have been In the beginning, just like across the world, there was concerns about personal protective equipment and all of that. So I guess there's two issues. If you feel, and this is true for anybody in the hospital, that you are in a particular high-risk group, I think they've been very receptive about deploying you to an area that could be considered less risky, but that's been left up to sort of personal choice. But I will say it is not looked down on. Like if people feel they're in a high-risk group for whatever reason, that there is some personal choice and there's an effort made, because you can be deployed to lower risk areas and still feel like you're a part of the team. And then the second thing is, I don't know if you've heard about this, but there has been a collaboration with industry to re-sterilize the N95 masks, and Partners Healthcare has been helping to build a site in Somerville. So I think that has relieved a lot of the stress for the healthcare providers, because we are now beginning re-sterilization of the N95 masks on a pretty large level. And I think that's making people feel better as well. We're also having many, many, many sessions and webcasts about appropriate donning and doffing and, all of those kind of things. But I do think that the ability to have more personal protective equipment, particularly the N95 masks, and with this collaboration with industry, is making all the healthcare providers feel more comfortable. And it's nice to see, for example, there is a sneaker company in the Boston area, New Balance, that is making elastics for the re-sterilized masks. So
brilliant.
I think it's kind of nice the way that all these I thought that was just brilliant, that they're experts at rubber or whatever you do in sneakers. And the thing that you can't do in a re-sterilized mask, the elastic isn't strong. But I think that these are great collaborations that are happening.
I wanted to ask you about, we've talked a lot about in this last bit of the conversation about people being concerned and healthcare providers and their stress and anxiety that they have going in. Are you guys doing anything there for health and wellness for your providers?
Yes. Well, it's very funny. I don't know what you're doing in England, but we have yoga webcasts. Yesterday we had plastic wrapped milk and cookies that got delivered to everyone in the hospital.
We absolutely. We're getting incredibly well looked after by the local businesses.
Yes.
Thank you to everyone.
Right. Coffee companies are donating. I have to say, I appreciate the sensitivity that all of the local businesses have had to these little things. They make a difference. They make you feel cared about. I don't know if you've heard about this, because my daughter is in New York City, but at 7:00 every day in New York City, they all open their windows and cheer for healthcare providers. Have you heard that?
Yeah, I've heard
that. Seven in the morning? That would go down like
in the evening.
Okay, yeah, that's cool. I thought 7 in the morning. I thought that would go down like a lead balloon around here.
I know, but and you know what? She says that's the most important part of her day. And she's in banking. She's not in healthcare. So she had me on the video when it was happening, and literally all across New York City, you can just hear people cheering, and they've made this appointment at 7 every day, which is very nice.
Oh, that's absolutely fantastic.
Yeah,
that does, and it does make a difference. As someone that's worked out on the front line and pretty stressful situation, whenever you have people acknowledging the work that you're doing, especially in something like this, it does. It's a little bit, it helps boost your day. That is for sure. Well, Angela, it's always a pleasure and so wonderful to catch up with you. I know that there are some things that you were working on before the COVID crisis kind of happened. And so we hope to catch up with you.
Yes, definitely.
About some of the work that you've been doing over the last year. And hopefully maybe in the next couple of months, maybe a month or so, we can do that. But thank you for all the work that you're doing in your community there.
Well, thank you so much for inviting me. It's such a pleasure to talk to you. And right now, I will be at EdPom in Chicago, assuming there is an EdPom in Chicago in the fall as faculty. So I don't know, hope to touch base with some of the group there, and looking forward to speaking with you in the future.
Yeah, absolutely.
Well, EdPom is going to be firing up a virtual conference in anticipation of us getting together physically in Chicago and other meetings that are planned, but also preparing for the fact that we might not all be able to travel. So we've got a plan, Angela. So some of us will definitely physically see you, but if not, we'll all virtually.
Okay, great. No, I'm looking forward to it, because at least now my schedule as a speaker is getting back to my normal, interests, geriatrics, cognitive issues, etc. But who knows what'll happen by then. So we'll see. I look forward to it.
Yeah, absolutely. Well, for all of our listeners out there, thank you so much
Thank you, Desiree. Stay safe.
You too. Thank you so much, Angela. Talk to you soon.
Top Med Talk.
Thank you for listening to Top Med Talk. You can always find us on Twitter, LinkedIn, Facebook, and on topmedtalk.com. We want everyone to stay safe. If you have any questions or you want to talk to us on Top Med Talk, please reach out via contact@topmedtalk.com. That's contact@topmedtalk. Thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.